Today I shall talk on obstetric surgeries. So I shall take up two topics, that is episiotomy and caesarean section. Episiotomy is the commonest operation that is performed in obstetrics. It is a surgically planned incision made on the perineum and the posterior vaginal wall during the second stage of labor. The objectives are to enlarge the vaginal introitus so as to facilitate easy and safe delivery of the fetus, to minimize overstretching and rupture of the perineal muscles and fossa, and to reduce the stress and strain on the fetal head. The indications. It is performed in inelastic perineum, particularly in primigravida. Then whenever we anticipate some kind of perineal tear, we have to perform an episiotomy. And in case of instrumental vaginal deliveries like in forceps or ventouse application, women with previous perineal surgery, like if she had a previous pelvic floor repair or pelvic reconstructive surgery, she will require an episiotomy. Then in case of breech delivery, occipito-posterior delivery or face delivery. When do we need to perform episiotomy? So when we see that the perineum is bulged and thinned out during an uterine contraction just prior to crowning of the fetal head, that is around 3 to 4 centimeter of the fetal head is visible. During forceps delivery, it should be made only after application of the forceps blades. If it is done too early, the blood loss will be more, and if it is performed late, it fails to prevent the very purpose for which it is being made. That is, it cannot prevent the lacerations of the perineal body. Advantages of episiotomy. For the mother, there is better repair than a perineal injury that may occur if you do not perform a episiotomy. Then reduction in the duration of the second stage, and the trauma to the perineal muscles is also reduced. For the fetus, it helps to minimize intracranial injuries. What are the types of episiotomy? So there are 4 types of episiotomy: median, mediolateral, J-shaped and lateral. So the commonest one which we perform is mediolateral. Here the incision is made downwards and outwards from the midpoint of the forceps, either to the right or to the left. It is directed diagonally in a straight line which runs about 2.5 cm away from the anus, that is midpoint between the anus and the ischial tuberosity. Then median episiotomy. Here the incision commences from the center of the forceps and extends posteriorly along the midline for about 2.5 cm. Lateral. The incision starts from about 1 cm away from the center of the forceps and extends laterally. It has got certain drawbacks, like there is chance of injuring the Bartholin's duct. Then J-shaped. Here the incision begins in the center of the forceps and is directed posteriorly along the midline for about 1.5 cm. Thereafter, it is directed downwards and outwards along 5 o'clock or 7 o'clock position so as to avoid the anal sphincter. The apposition in this kind of episiotomy is not perfect and the repaired wound tends to be puckered. So coming to the steps of mediolateral episiotomy, which we generally perform. First of all, we need to swab the perineum thoroughly with antiseptic solution and drape it properly. Then in the line of proposed incision, we infiltrate with 10 ml of 1% lignocaine solution. 2 fingers are then placed in the vagina between the presenting part and the posterior vaginal wall. The incision is now made using a curved or a straight, blunt pointed sharp scissor, one blade of which is placed inside in between the fingers and the posterior vaginal wall and the other on the skin. The incision should be made at the height of an uterine contraction, starting from the center of the forceps and extending laterally either to the right or to the left, and is directed diagonally in a straight line which runs about 2.5 centimeter away from the anus. The incision should be adequate enough to serve the purpose for which it is needed. What are the structures cut during an episiotomy? The posterior vaginal wall, superficial and deep transverse perineal muscles, the bulbospongiosus and part of levator ani muscles, then fossa covering these muscles, transverse perineal branches of pudendal vessels and nerves, subcutaneous tissue and skin. Coming to the repair of an episiotomy wound. For this, we need to put the patient in a lithotomy position and we need a good light source. Patient is draped properly and repair should be done under strict aseptic precautions. Repair is done after expulsion of the placenta in 3 layers. First is the vaginal mucosa and the submucosal tissues. The first suture should be placed just at or above the apex of the tear. Thereafter, the vaginal walls are opposed with polyglycolic acid suture or chromic catgut from above downwards till we reach the foreset. The suture should include the deep tissues so that any dead space is obliterated. The second layer is the perineal muscles. And finally, we stitch the skin and the subcutaneous tissue. The principles to be followed during repair are: there should be perfect hemostasis, any dead space should be obliterated, and suture should be made without any tension. Post-operatively, we need to take care of the wound. So, we should ask the lady for regular dressing of the wound. Then we may apply magnesium sulfate compression or infrared heat, ice pack or analgesics for comfort to the wound. Early ambulation is advised, and if non-absorbable sutures are used, then we advise removal of stitches on the 6th day. What are the immediate complications of an episiotomy? So it may extend to involve the rectum. This is particularly seen if we give a midline incision. Then vulval hematoma, if proper hemostasis has not been achieved. Then there may be infection, particularly where we do not take proper aseptic precautions. So what are the signs of infection? She will complain of throbbing pain on the perineum, rise in temperature, the wound area would look moist, red and swollen, and sometimes there may be offensive discharge from the wound. Treatment of infection: take steps to facilitate drainage of pus, local dressing with antiseptic powder or ointment, make self-compression or application of infrared heat so as to reduce edema and pain, and use of antibiotics. And if we use systemic antibiotics, it's better. There may be wound dehiscence. There may be injury to anal sphincter causing incontinence of flatus or feces. Patient may develop rectovaginal fistula, and rarely there may be necrotizing fasciitis, particularly in a woman who is diabetic or immunocompromised. Remote complications are dyspareunia, chance of perineal lacerations in subsequent labor, and rarely scar endometriosis. So this is a diagram showing mediolateral episiotomy and midline episiotomy. So another diagram where we can particularly see a schematic view of mediolateral incision and repair. Now we come to caesarean section. Caesarean section refers to the delivery of a fetus after the age of viability through an incision made in the abdominal wall and the uterus. This definition does not include removal of a fetus from the abdominal cavity in case of rupture uterus. WHO recommends an ideal caesarean rate of 15 to 20%. So let us go back to history of caesarean section. So it goes back to 715 BC when Numa Pompilius, the the king of Rome brought in a law which forbade the burial of pregnant women unless her child had been removed from the abdomen and buried separately. The first recorded successful caesarean section was done by Jacob Neuffer on his wife of prolonged obstructed labor in 1588. According to legend, Julius Caesar was born by this operation. It was initially a fatal operation until the beginning of the 20th century. What are the factors responsible for increased rates of caesarean section? One is there is increase in the number of repeat caesarean rates. Then decrease in number of difficult instrumental vaginal delivery and also vaginal breech deliveries. Then increased diagnosis of intrapartum fetal distress because of the use of intrapartum electronic fetal monitoring. Then caesarean section on demand. Then better identification of risk both of the mothers and fetuses. Then increased number of pregnancies by in vitro fertilization. And also medical legal concerns are also responsible for the increased rates. Indications of caesarean section. Previous caesarean section, then dystocia or dysfunctional labor, fetal distress, malpresentations, antepartum hemorrhage due to placenta previa, multifetal gestation, cephalopelvic disproportion, maternal medical conditions, caesarean section on demand. What are the types of caesarean section? So based on the type of incision on the uterus, there are mainly two types. One is the lower segment caesarean section, which is widely practiced, and the classical or the upper segment caesarean section, which is almost obsolete nowadays. Then based on the timing of performing caesarean section, it may be an elective caesarean section, which is a planned caesarean section done with proper investigations and is generally planned after 39 weeks of pregnancy. An emergency caesarean section when it has to be done as an emergency procedure. Now, how do we prepare the patient prior to surgery? We need to counsel her, take a written informed consent. Preoperative evaluations have to be done. Then antiseptic preparation of the incision area, bladder catheterization. Then blood has to be kept cross-matched. Antibiotics are to be started, and sometimes we use heparin therapy as thromboprophylaxis. Then in the OT, we should ideally keep the patient in a left lateral tilt of at least 15 degrees. Then oxygen inhalation, pediatrician should be available, and the fetal heart should be auscultated prior to the procedure. Regarding anesthesia, we may opt for general anesthesia, but it has got a risk of aspiration and chemical pneumonitis, for which we should use antacids during labor, and oral fluids are to be withheld. The preferred anesthesia is generally spinal or epidural. Coming to the skin incisions. So generally we go for non-anesthetical incision where we put a transverse curvilinear incision above the pubic hairline, that is 2 fingers above the pubic symphysis, which is deepened through the subcutaneous tissue up to the rectus sheath. The rectus sheath is divided transversely. Here wound breakage is rare, it is cosmetically better, and chance of incisional hernia is rare. Next option is we may go for a midline incision, which is a faster procedure. It is easier to extend if required, and exposure is good. Then we may go for a paramedial incision. We may go for a Joel-Cohen incision, which is a straight incision 3 cm below the line joining the anterior superior iliac spines. Subsequent layers are opened bluntly and extended with scissors if required. Then Maillard incision. This option is chosen when more exposure is needed. The skin incision is made 5 to 8 centimeter above the symphysis pubis and the rectus muscles are divided. So this diagram shows the various types of skin incisions that we use in cesarean section. Next is opening of the abdomen. So the skin incision should extend well down into the fatty layers. Small incision is given in the rectus sheath and is then extended along the full length of the skin incision using scalpel or the dissecting scissors. The midline is identified and the recti separated. Next, the peritoneum is incised and the incision is extended by fingers or scissors. Once we are into the abdomen, dextrorotation of the uterus, if it is there, is corrected. Doyne's retractor is introduced to retract the urinary bladder downwards and for proper visualization of the lower segment. The peritoneum over the lower segment is identified as it is loosely attached to the lower segment of the uterus and this is divided transversely. Next, transverse curvilinear incision is made at 1 to 2 centimeter below the junction of the upper and lower segment. Gentle strokes with the scalpel is made and then extended laterally with curved scissor with curve upwards, or we may also extend it with our index fingers. Once the membrane is ruptured, we deliver the baby. If the space seems to be inadequate, we may go for a J-shaped or inverted T incision so that we do not injure the uterine vessels which lie lateral to the uterus. What are the advantages of a lower segment cesarean section? The lower segment is less vascular. So hemorrhage is less, there is less muscle damage. Suturing is easy because the opposed layers are thin. There is easy and rapid healing. Decreased risk of postoperative ileus and peritonitis. Also decreased risk of adhesion formation and obstruction. And in subsequent pregnancy, the lower segment scar is not under pressure and stretch. It stretches only during labor in subsequent pregnancy. The risk of scar rupture is around 0.5%. Coming to classical cesarean section. Here the incision that is made in the uterine wall is midline and longitudinal. There is technical difficulty in performing this surgery. Hemorrhage is more. There is difficulty in suturing because the layers are thick. There is increased risk of adhesion formation. Healing time is also longer. The scar remains under tension during subsequent pregnancy and can rupture even during the antenatal period and also during labor. The risk of rupture is around 2.2%. Indications of classical cesarean section are transverse lie with the fetal back inferior as a preliminary to cesarean hysterectomy, such as in cases where we are also treating carcinoma of cervix. Then previous classical cesarean section, presence of a large cervical fibroid, then placenta previa with large vessels in the lower segment, then preterm delivery with poorly formed lower segment, severe adhesions in the lower segment reducing accessibility, and in cases of postmortem cesarean section. Sometimes we may opt for low vertical incision, that is a vertical incision in the lower segment. This is done if the lower uterine segment is not well formed and also to cut contraction ring to deliver the baby. Now how do we deliver the baby? So in case of cephalic presentation, the head is slipped into the uterine cavity and the fetal head is levered out gently. For floating head, we may need to use a forceps. In case of breech presentation, the feet is hooked out first and then the rest of the body is delivered. In case of transverse lie, sometimes the uterine incision may need to be extended, and here also we try to feel the feet of the baby, bring it out, and then deliver the rest of the body. Now for delivery of the placenta, we need to go for active management of the third stage and removal of placenta by control cord traction. Manual removal is avoided as far as possible because it increases risk of hemorrhage and also of infection. Next, closure of the uterine incision. Oxytocin infusion is started as soon as the baby is delivered. This leads to contraction of the uterine fundus so that the placenta and membranes are extruded spontaneously and these are removed. The uterine cavity is wiped with a moist pad so as to ensure that it is empty. The edges of the uterine wound is held with Alice forceps or green Armitage forceps, and the incision is closed either in one layer or two layers with continuous sutures. Any bleeding points, if present, is sutured or coagulated. Then we may opt for exteriorization of the uterus for repair. The advantages are it helps in better visualization, it facilitates repair, decreases the blood loss, and there is no increase in febrile morbidity. But disadvantages are it may cause pain and vagal induced vomiting due to stretch. This procedure is not recommended by RCOG. So next we go for closure of the abdomen. In peritoneum, we may opt for closure or we may not close it. RCOG recommends that neither the visceral nor the peritoneum nor the parietal peritoneum be sutured during cesarean section because this reduces the operating time and the need for post-operative analgesia. The rectus sheath has to be well secured with non-absorbable sutures. With absorbable sutures to reduce wound dehiscence and incisional hernia. The subcutaneous tissue, routine closure is not required unless the woman has more than 2 cm of subcutaneous fat and skin is closed with mattress sutures of silk, or we may go for subcuticular sutures or application of clips. So this diagram, we can see the various type of incisions on the uterus. In the first diagram, we can see a lower segment transverse incision. Then second one, lower segment vertical incision. Third one is a J incision. Fourth one is a classical incision. And the fifth one is an inverted T incision. So here we can see some of the steps of cesarean section up to the delivery of the fetal head. Coming to the post-operative care. So we should monitor the patient closely for the first 6 to 8 hours. Then parenteral fluids and oxytocics are to be given, antibiotics and blood transfusion if required, then analgesics and sedatives depending on her requirement. Then we can start her on oral fluids and light solid diet after 6 to 8 hours provided the bowel sounds are present. We should advise early ambulation and deep breathing exercises, and sutures should be removed either on the 6th or 7th day after surgery. There is a term called extraperitoneal cesarean section which is performed in severe infection where our approach is extraperitoneal through the space of Regius, that is the paravesical space. What is cesarean hysterectomy? So sometimes we need to perform hysterectomy during cesarean section. Indications are in case of severe atonic postpartum hemorrhage, then placenta equita, inquita or perquita, presence of sepsis, multiple large fibroids or presence of carcinoma cervix. Complications of cesarean section. First, the intraoperative complications like primary hemorrhage, injury to internal organs like bladder or bowels, injury to the baby, difficulty in delivery of the head, and anesthetic complications like aspiration syndrome or hypotension. Postoperative complications. She may develop paralytic ileus, which can be prevented by initiating early oral intake. And respiratory complications may be avoided by promoting deep breathing exercises. Patients may develop infections like wound infection, peritonitis, pelvic abscess, and pelvic thrombophlebitis, which may be prevented by aseptic precautions and use of antibiotics. Then deep vein thrombosis and pulmonary embolism. Sometimes wound dehiscence as a sequelae of wound infection may occur. And thromboembolism is also a major cause of maternal morbidity as well as mortality. It is seen more in cases of emergency LSCS or in case of advanced maternal age, obesity, or inherited thrombophilic disorders. To prevent it, we can use mechanical cuff compression intraoperative and postoperative and use of low molecular weight subcutaneous heparin. Late sequelae. This includes secondary postpartum hemorrhage, incisional hernia, scar endometriosis, vesicovaginal fistula, scar rupture in the next pregnancy, placenta previa and placenta accreta in the next pregnancy.